Top Med Talk.
This is Top Med Talk, the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. The EBPOM World Congress is taking place this year between the 7th and the 9th of July at the British Library in London. Check out ebpom.org now.
Hello and welcome to Top Med Talk. We are here in Montreal, Canada for SOAP, the Society for Obstetric Anesthesia and Perinatology. I'm Desiree Chappell, guest hosting here, but former co-editor-in-chief of Top Med Talk. And I'm joined by the former official editor-in-chief.
The founding editor.
You all know that voice. Monty Mythen. Hello, Monty.
Good, Desiree. It's good to be back.
It is. It's been fun. We've been pretending that we're back on Top Med Talk officially.
Well, Professor Mike Grocott, who's the new editor-in-chief, had to dash off too because there's actually two meetings in parallel here. The International Anesthesia Research Society in parallel with SOAP, which you've just heard about.
Yeah.
So he's had to run down the road. So he said, Monty, could you jump in?
That's right.
Delighted to be here.
Absolutely. It's good. So meeting, we were here 2 years ago. It was fantastic, and we thought we need to go back. And SOAP has been gracious to lend us the space and get us set up here. So thank you to the organization and the board of directors for supporting us to be here. It's been a really great meeting so far, I think.
Excellent.
Our guest today, I think we're going to do a deep dive into hemodynamics. We are so fortunate to have a friend join us today, Dr. Marie Louise Meng. Marie Louise, if I may. Thanks so much for joining us.
Thanks for having me. I really appreciate the opportunity to talk a little bit about what we do in cardio-obstetric anesthesia.
So for all of our listeners, why don't you tell us a little bit about your background? Because it is very diverse and you do lots of different things, but you kind of have one sole focus.
Yeah, so I trained up at Columbia University in New York City. A shout out to my very loving clinical mentor, Rich Smiley, who's not here this year. Rich was a cardiac anesthesiologist who moved over to the labor floor and really built up the division of obstetric anesthesia at Columbia. And I was fortunate to train under him. And so that model of a cardiac anesthesiologist being an obstetric anesthesiologist was there from day one for me. I'm really grateful for that. I'm also grateful to Margaret Wood, who opened the door so that I could do both fellowship in obstetric anesthesia and cardiac anesthesia at Columbia and stay there as faculty, where for the first 3 years of my career, we really defined what is cardio-obstetric anesthesia, wrote a bunch of reviews about how to care for these patients safely. Then I was fortunate to be recruited down to Duke, where I learned how to write specific AIMS pages and start getting into research a little bit more in the preeclampsia space, which is the cardiovascular disease of pregnancy, and also where I had the opportunity to mentor some really amazing up-and-coming junior faculty, one of which is sitting right next to me. I'm honored to be joined by my very first fellow, a cardio-obstetric fellow, Liliane Ernst. So Liliane did both OB and cardiac anesthesia fellowship at Duke, and she's now in her second year as an attending at Wake Forest.
Thank you. Yeah, thank you for having me.
Awesome. Thanks for joining us. So where are you from originally?
I grew up mainly in Knoxville, Tennessee.
Oh, okay. And you're at Duke currently?
I'm at Wake Forest.
Oh, Wake Forest.
Yeah,
I'm sorry. That's right. You said that. Yeah. Yes. Great. So, and how much longer do you have in your fellowship?
I'm done. I'm in my second year as an attending.
Second year as attending. That's right. Okay, great. So you guys have been working together on any projects or research that you're doing?
Yeah, I actually pulled Liliane over from editing a manuscript over there.
Yeah.
Liliane looked at, thanks to FAIR, where we got the funding for a big data set that we've been using to look at outcomes in patients with different types of cardiac disease in pregnancy. Liliane has been specifically looking at women who have atrial fibrillation and the management and outcomes of these patients in pregnancy. So, I don't know if you want to share a little bit about what you've been working on.
Yeah. So we know that arrhythmias are one of the most common cardiac complications that pregnant women face, and atrial fibrillation is one of the most common of those arrhythmias. And there's not that much information out there about the outcomes of these patients and management of these patients. So I really wanted to, with the Premier database, see how do these women do, what kind of issues and outcomes and complications do they have, and we can use that information to then guide further management and recommendations.
For the broader audience, is this atrial fibrillation that occurs as a result of being pregnant? And does it tend to go away when the baby goes away in the happiest way?
So for our study, or this specific study, we are only looking at preexisting atrial fibrillation, meaning atrial fibrillation that occurred sometime before delivery hospitalization.
So what is the incidence then? I don't know. I didn't even realize that was a major issue in the obstetric patient.
Yeah. In our cohort, it's about 25 per 100,000 deliveries.
Oh, okay. So, yeah. Because I think of it as like EP lab treating, doing ablations and stuff like that. And no obstetric patients, of course. Well, Marie Louise, why don't you tell us a little bit more about some of the areas of interest that you have in some of the work that you've been doing over the last couple of years?
Sure. So one of my main interests is making sure that women with complex cardiac disease get the appropriate care to get them through their pregnancies safely, but also doing that in a really thoughtful way so that our patients don't feel like they're critical or that they're high risk, so that they have pleasant birth experiences and we minimize the birth trauma that you imagine could come along with a woman who has cardiomyopathy, an EF of 30%, has been told that she shouldn't get pregnant, but she really wanted to get pregnant and got pregnant. And it's an important life event for her to be able to carry this pregnancy to term and have the baby and then do well postpartum. So yes, we know how to do a low dose neuraxial anesthetic, keep her safe, place an arterial line or use non-invasive monitoring as we need to keep her safe. But what is her experience through that? Does she sense that the whole team is really concerned and really worried and that she's really sick? Or does she feel like her providers really understand her disease and they're walking her through what needs to happen in a calm, collected team manner? So that's really what we've been building is pregnancy heart teams so that before she shows up, we all meet cardiologists, obstetricians, nurses, social work, anesthesiologists, present the patients, present their progress, make the plans so that at 3 a.m, you don't need a cardiac OB anesthesiologist. Any general anesthesiologist can read the plan, and we write it in a friendly way such that if you need to make adjustments to the plan, we're not tying anyone's hands to any sort of management, but we can be thoughtful about what the provider may need to know when she presents. And I think our space needs to move towards what are the important outcomes. So yes, we can get them through, but what are the patient-centered outcomes? What are the provider-centered outcomes? Do the providers feel supported in the care of these patients? And then what are the clinically meaningful things? If we're looking at ICU stays, what are those ICU stays for? There's a lot of birth trauma if a woman goes to an ICU and didn't need to and she's separated from her baby. So can we bring some of that critical care to the labor floor and really elevate what we're doing for our cardio-obstetric pregnancy heart moms and bring that also to our other moms? So in the hemorrhage setting, in the preeclampsia with severe feature settings, all of this kind of trickles down to every obstetric patient.
Yeah. And a similar question, the one I asked about the atrial fibrillation, are these mainly mums who knew they had a problem with their heart before they got pregnant? Or does some of them discover that when they become pregnant? Or does some of them have a heart challenge because they're pregnant?
So I'm currently at Vanderbilt, and at Vanderbilt, our pregnancy heart team is very busy. They see about 400 pregnancy heart consults during pregnancy. So these are women as outpatients. So that's 400 women with known cardiac disease every year. On top of that, there's about 300 inpatient consults, some of which are those same patients. About half of them are de novo disease. And a lot of that is what we see, obesity cardiomyopathy or other forms of cardiomyopathy or other forms of decompensation like preeclampsia with severe features. And then you have a postpartum heart failure event. So our team's very busy and it is a mix of both.
Because historically we assumed, I'm pretty old now, but in the last century when I was doing OB anesthesia as a young doctor, this sort of background assumption was, young women are fit people. And young, fit people have babies. Sick people don't have babies. But that's changed dramatically over the decades, isn't it?
Yeah, and you're bringing up a very interesting case. And I think the patient has even published an article about it. So, and Liliane has her permission to talk about it. But last year, Liliane and her team cared for a woman who had, it was ischemic cardiomyopathy at 25 weeks. And the team was able to place an Impella in the mother to get her through 2 more weeks of pregnancy. So basically getting that neonate from 25 weeks to 27 weeks was pretty incredible.
For people who don't know, Impellas, it's sort of like a temporary artificial heart support that goes into the body. Is that right? That
exactly.
Gives it a boost.
Exactly.
Wow, that's amazing stuff.
Yeah.
How'd she do? Walk us through a little bit about that.
So she ended up delivering at 27 and 2 weeks gestation just because there were some signs of potential uteroplacental insufficiency. So with shared decision-making, we determined this is now the right time to deliver the baby. We scheduled the C-section in our cardiac ORs. Baby was delivered, initially had to be intubated, but was extubated on day of life 2 to nasal CPAP. And then mom had the Impella removed on day 2. And she continues to be followed by our heart failure team with multidisciplinary management and kind of managing the next steps of optimizing her function.
I think that case really highlights the range of what we're doing in cardio-obstetrics. Right? We don't know what the circulation with mechanical support does to the placental circulation. So seeing fetal instability makes sense. And we don't know how long we can take these devices and how long we should be growing these fetuses like this, right? So that's what our field needs to answer. And that's why it's really important to publish these as case reports, because there's no way to do a randomized controlled trial of that, you know? So we have that, and then we have our field trying to just bring awareness to heart failure peripartum. That's not all peripartum cardiomyopathy. A lot of it is she had severe range blood pressure. She had 200 over 100 for 24 hours, and it wasn't treated, and that LV is going to blow out. It's going to fail with that pressure, right? So bringing recognition to the importance of blood pressure management, recognizing heart failure. It's not flash pulmonary edema. It's flash. All of a sudden you recognize it as the clinician. So being able to use hemodynamic monitoring to identify these instabilities, and instability in the hypertensive side is as important as hypotension in our pregnant and postpartum patients.
I'm guessing because, you know, we've learned quite a lot over the years about the performance of the endothelium, for example, and there's great discussions about the importance of pulsatility in some organs. I never remember anyone telling me what the placenta thought about that, for example, because I'm not sure until we've had Impellas, you know, the sort of less pulsatile, high maintained flow state hasn't really been a discussion point. I'm guessing we don't know much about it yet.
Some of the information that we do have is for Fontan patients that do not have necessarily completely pulsatile circulation.
Can you re-explain that to the broader audience?
Yeah. So
some of them will probably say, I kind of remember that.
Yeah. A Fontan patient, or a patient that has Fontan physiology, is when they have passive flow to the right side of the heart. They essentially don't have a right ventricle. And in these cases, with this lack of pulsatility, or that you still have somewhat of pulsatility, but on the right side of the heart, you don't have pulsatility. When you look at the placentas after delivery, they're not normal. And they have a high incidence of miscarriage, stillbirth, and even getting pregnant in these patients. So we know that their placental perfusion isn't normal.
Oh, fascinating.
Marie Louise, you've done a lot. I mean, having the cardiac piece to this and working with those types of patients. Talk to us a little bit more about the hemodynamic monitoring and how that works for the, you know, all the different types of disease that you were talking about. I know in one of the sites where I worked, we had an adult congenital, and we also took care of some very sick patients. And I think we were just getting into that space. So talk to us a little bit more about the value of having that for those patients.
Sure. So, you know, we're seeing women who are either laboring, and so they're having uterine contraction pain and pain of cervical dilation, and then pain through the delivery of the fetus. Or we're seeing women for C-sections, right? The anesthesia for both of those is slightly different. One is a bit lighter, right? Because we're just taking away pain during vaginal delivery. But for a C-section, you're taking away surgical stimulus pain, right? So you need a much denser anesthetic, and the level of that anesthetic needs to be much higher. It needs to come all the way up to the level of the breasts, basically, so that she's comfortable. And with that, we know that we see hypotension. And so traditionally for a patient with cardiac disease, we usually try to have them, if the obstetric exam is favorable, if the fetus is doing well and the mom is not decompensating from a cardiopulmonary status or cardiopulmonary reason, the OBs will suggest a trial of labor, because we think there's less of hemodynamic instability than with a C-section, less risk of infection, less risk of thrombosis, less risk of bleeding. But sometimes we do C-sections. And so when you do the C-section anesthesia, you really, in your more higher risk women with certain cardiac diseases, you may want to raise that level of anesthesia a little bit slower and titrate your vasopressors over time so that you never really have hypotension, right? And so we want to do that for all of our patients, but certainly a young, healthy woman with no cardiac disease will tolerate swings in blood pressure a little bit better than a patient with, say, mitral stenosis, aortic stenosis, HOCM. Those are some of the higher risk lesions in pregnancy. Patients with aortic disease with larger diameters of their aorta. There's a full range, there's a full spectrum. And the WHO has done a nice job of putting into different groups, 5 different groups, like maternal risk from low to high. And so as anesthesiologists, we kind of use that WHO guidance to determine what type of monitors we should be using for these patients. So a woman who just has atrial fibrillation, but it's not with RVR and she's stable, she's not going to need an arterial line, right? She's just going to need a blood pressure cuff and telemetry if she's coming for a C-section, right? But if you have a woman with a cardiomyopathy with a lower ejection fraction who's symptomatic, you might be placing an arterial line or want non-invasive continuous blood pressure monitoring in that patient. So it really depends on what her cardiac disease is, what we decide the monitoring should be, and what you're doing for the anesthesia.
I was going to say, for we interviewed, I think, one doctor who revealed that they had developed a postpartum cardiomyopathy, completely fit and well. And I sort of remember cases like this coming to critical care, completely fit and well, a baby comes out nicely, everything's going well, and then they try to go home and the heart's just not working very well. So do we screen for that now, or do we just wait to see if the mums are okay when they go home?
That's a great question. Do we screen for that? Well, hopefully we're not discharging anybody who's not feeling well. The nurses are going to be doing vital signs and making sure that no one's tachycardic or hypotensive before we send them home. If anything, I worry on the opposite side that women are a little too hypertensive. But most women only have one postpartum visit, and a lot of women don't even show up for those visits, right? They're busy with their newborn, or they have social drivers of health that prevent them from having those checkups. And unfortunately, the higher risk patients overlap with those patients that have those social drivers of health. So I think that we need to do a better job of remote monitoring for our patients, making use of wearable technology, making use of telemedicine. American Heart Association and ACC have really nice documents about how obstetricians and cardiologists should be creating postpartum clinics for patients who've had hypertensive disorders of pregnancy, which is a big risk factor for developing a cardiomyopathy after pregnancy.
If I remember this interview correctly, you can find it on Top Med Talk, but the challenge as I took it was that when you told the mums to go away and if they're feeling X, Y, and Z, that they should contact somebody, what they're looking out for is normal for having had a baby being post C-sections. They say, well, if you feel tired, if you feel short of breath, if you feel so and so, well, as I remember, that's every day.
It's still 12 years later for me. But
well, I think, Monty, what you're bringing up is how important the patient perspective is in everything we do. And the cardio-obstetric world has been doing a great job of including patients in our guidance and including them in our outcomes. Because I don't know what it feels like to be postpartum. I don't know what it feels like to have heart failure, and the women who have recovered from these things, their voices are so important in shaping what we do for our patients. A lot of lessons we've learned from Melissa Bauer in the maternal sepsis world. She does a lot of work with the patient experience, the patient coming to the emergency room just not feeling well, and they completely miss the fact that she is immediately postpartum. And so those voices really help us understand the gaps in our healthcare.
And she was telling us about her experience, and she's like, I just go home and I just felt like I just had a baby. I didn't feel great. I kept talking myself out of that this could be something more.
Yeah, I heard you interviewed her.
Yes.
I need to go back and listen to that.
Should.
She's wonderful. She's such a strong woman, and she's an obstetric anesthesiologist.
I think the only one in Mississippi, actually, or maybe one of two. Very rare. I mean, and they live in a major desert there. So switching gears just ever so slightly, we talked about like cardiomyopathies and that side of things. Preeclampsia is something that we hear all about. I mean, with advanced maternal age, I don't know if you know the rate of preeclampsia or preeclampsia with severe features. The severe feature part was something that was kind of a newer phraseology for me, not doing obstetrics. Can you just walk us through a little bit about that?
Yeah, sure. So this is actually really important to highlight in medicine. And I know we have a lot of different types of physicians listening to this. We should be asking our patients their pregnancy history. If you're meeting a 50-year-old woman as her cardiologist, as her nephrologist, as her neurologist, as her primary care doctor, you should say, were you pregnant? Tell me about your pregnancies. Did you have, we call them adverse pregnancy outcomes, APOs. So if you have an APO, which is gestational hypertension, preeclampsia, gestational diabetes, small for gestational age, premature baby, you have a much higher risk of developing cardiovascular disease much earlier in life. So we don't know chicken or the egg. We don't know if the APO unmasks the cardiovascular disease or the cardiovascular disease is a risk factor for the APO. It may be a mix of both. It may be different for certain patients. Our research group is trying to work on prediction models for who's going to develop accelerated cardiovascular risk factors. And so preeclampsia, to answer your question, is a very important thing for us to all be aware of and remember. So it's about 20% of women in America have a hypertensive disorder, meaning chronic hypertension, or they develop gestational hypertension or preeclampsia. About 7% of pregnancies are pregnancies with preeclampsia. 40% of those, almost half, almost 3% of pregnancies have preeclampsia with severe features. And what that means is that there's end organ damage. So there's 6 different severe features, and I'm going to editorialize here. I think heart failure should be the 7th feature. I think, some of us pair it with the pulmonary edema, but the two things are different, and you can have one without the other. But if we talk about the end organ damage, we're just going to go through the systems. So cardiovascular, severe range blood pressure, so it's going to be 160 over 110. Now that's wildly high, right? Even just having pregnant women have 140 over 80 is probably too high for their age, right? So the obstetricians are doing a great job on redefining hypertension criteria. Next, we have neuro. So you can have a headache or you can have a seizure. We move down to the liver. So you can have elevated LFTs, and that often becomes what we call HELP syndrome. And that's coupled with hematologic syndrome, so low platelets. And then, like I said, we have the pulmonary edema, which could be heart failure. In our group, we have an abstract here, Adrienne Shami from Duke, showing in women with severe features. We did echoes on them, and about a third of them have diastolic dysfunction and LV strain impairment. Most echoes are not looking at these things in young women, so that really needs to be added on to the echoes. And then finally, we have renal failure, so an elevation in creatinine. And so the women are pregnant and they develop these severe features, so it's end organ damage, and the only treatment is delivery of the fetus in the placenta. And so you can imagine that means sometimes we're having premature babies. And there are disparities in this disease. There are more women in America who are Black who have preeclampsia with severe features, meaning the next generation is born premature. So that the complications of this disease are passed on to the next generation. And so our research group at Duke, UNC, and Brigham, we've been looking at all of these issues kind of from a multidisciplinary, multi-generational perspective.
Yeah. Gosh, that's fascinating.
And it's because classically we were taught, as you said, get the baby out, get the placenta out, it all goes away. But I think what you were just telling me is if there was any APO,
it doesn't all go away. Exactly. I stand corrected. Yes, it doesn't. And that's the biggest thing, Monty. You hit the nail on the head.
So it's a cardiac risk factor that should be factored into any question.
Exactly.
When you're trying to evaluate cardiac risk. I'm not seeing it in any of the sort of classical cardiac risk scores.
Yeah, they're working on it.
Yeah, that's great. I've never been asked about my pregnancies, how they were, anything like that.
Yeah. When I was a fellow up at Columbia, I asked all my female patients during my cardiac fellowship, do you remember your pregnancy? Did you have high blood pressure in your pregnancy? And they remembered, and more often than not, than I expected, said yes.
Yeah. So we have preeclampsia with severe features. They're harder to take care of. I mean, that's one thing I remember specifically from my OB training. They're more difficult to take care of.
Yeah. I mean, we have to be thinking about their blood pressure in a different way, right? So, if we were taking a patient for a stat C-section and she doesn't have anesthesia and we're about to induce general anesthesia, I'm thinking about that laryngoscopy and what's going to do to her blood pressure and making sure that I'm keeping it low enough if she's already coming in 160 over 110, right? I don't want her to have a stroke.
Yeah.
And what we've found with some of our research also, Tori Brookshire from Duke, the research she's presenting here shows that what we found in our women with preeclampsia with severe features who had general anesthesia, there was a much higher rate of postpartum hemorrhage in the people who had uncontrolled hypertension, which makes intuitive sense, right? So we're seeing more bleeding in these patients. We may have challenges with fluid management. So when they bleed, their heart rate may go up, but their blood pressure may not go down. And so their hemorrhage may not be recognized, or their under resuscitation may not be recognized because their blood pressure is fine.
It's a longer conversation for another day, but it's not clear to me that the pathophysiology has been explored to a point whereby the people who are making pharmacological interventions are interested enough in solving the problem. Or is that just an old
Monty, it's women, Monty. It's women. So
That's why. So there you go.
if men got preeclampsia, you're right.
We would definitely know all the answers.
But you think it'd be, I get that was the point I was sort of getting at. Yeah. You think there must be some great targets there. What are we missing on that?
Yeah. So I really do love the non-invasive monitor.
Mm-hmm.
I learned today that we used to measure blood pressure by the finger, or that was like the original plan for blood pressure should be measured on the finger. But these non-invasive finger cuffs can give you also SVR, like systemic vascular resistance, and cardiac output. And so in your patient with preeclampsia, you can see, wow, she's really got a hyperdynamic heart and her SVR is high. So maybe labetalol is the right medication for her. Versus another patient who's maybe not hyperdynamic and maybe she's got a little bit of a cardiomyopathy, but she's got such a high afterload. And you just want to use a calcium channel blocker. You just want to use nicardipine to bring that blood pressure down. And look, I'm just an OB cardiac anesthesiologist. I'm not a maternal fetal medicine doctor. I'm not an obstetrician. I am not prescribing these medications during pregnancy or postpartum. Real serious caveat there. I'm taking care of these patients peripartum in the OR and on the labor floor. But that's how I think about those hemodynamics.
But I know those drugs, and that's what I used to do. If you
I know. You're saying we haven't done much work in the last few decades, Monty.
or not you. I'm saying is that you'd think that...
we should have advanced a lot more than we have.
Pharma would be all over it, and somehow. Anyway.
Are you listening?
Yeah.
Yeah. I need to send this one out.
Call them.
Yeah, I think there are definitely some amazing MFMs who are looking at these questions and what can we learn from the patient through her pregnancy about her hemodynamics non-invasively to help guide her antihypertensive management.
Yeah. I think the messaging, Mike and Grocott and I were talking earlier today, the messaging of the maternal mortality in the U.S. and how it is much worse than pretty much everywhere else in the world. We're pretty low on the list, but I think that is becoming a little bit more mainstream. People are learning about that, and then realizing that there's actually a problem.
Yeah. Well, that's a nice segue to another part of the world. So, Liliane, I'm really proud of, and you should be really proud of, the global health work that you've done and that you will be doing. I'd love to hear a little update about that.
So far, my global health work has been based in Ghana, Accra, Ghana. And a lot of it right now is just education in terms of educating and doing hands-on experiences for the providers there so that it's a sustainable global health intervention for that. In terms of cardio-OB specifically, when we look at areas that have high rates of peripartum cardiomyopathy, a lot of it is sub-Saharan Africa. And as far as the resources that are available, that is definitely kind of the next step in cardio-obstetrics, is making the management and interventions equitable and accessible in these low and middle income countries. And for example, in Ghana, there is a big range in the resources that are available. Like you can have a brand new, beautiful university hospital, and then you can go to a regional hospital or a government military hospital, and the resource availability is really different.
That are part of the ASA and WFSA specifically, and heard some of the work that's being done there. And we just were at the World Congress of Anesthesiologists last week, 2 weeks, I don't know, whenever it was, and did an interview with some women researchers, physician, professor, who are just doing some incredible work around this space as well. And we talked about, it was about HIV actually in pregnancy, which is very cool. So there's some good stuff out there.
And it's out on Top Mode Talk.
It is out on Top Mode Talk. We just released it last week.
638 patient study.
Yeah, you guys did some interesting hemodynamics in those patients.
We did.
Yeah.
They did it. We just enabled it. But they did that study in under 6 months.
Yeah, incredible work. But there are some amazing, amazing people who are really changing the world and what it looks like in Africa to care for the perioperative patient, and the obstetrics for sure is doing well. So that's fantastic. But I think we have to wrap for the day. But I hope that we can have you guys back and talk a little bit more about your experience with monitoring and some other things that you've been doing. So
sounds great. Thanks for having us, Desiree and Monty.
Thank you.
Thank you.
It's been great.
And thank you for listening to Top Med Talk. You know, you can always find us at topmedtalk.com. Be sure to check us out there. There's a great search function there. You can find us on your favorite podcatcher. And if you see us on social media, give us a thumbs up, give us a shout out. We love that. That helps us. Thank you to our sponsors and SOAP for, like I said, giving us this awesome booth here right in the middle of all the action. And thank you to our sponsors, GE Healthcare and Becton Dickinson Advanced Patient Monitoring. So thanks again for listening. Cheers.
Top Med Talk.
Top Med Talk is the broadcasting arm of EBPOM, evidence-based perioperative medicine. Join clinicians from around the world at EBPOM World Congress 2026 between the 7th and the 9th of July at the British Library in London. 3 days of evidence-based perioperative medicine, global insights and expert debate, featuring speakers including Michael Marmot and Ken Rockwood. Go now to ebpom.org. That's ebpom.org.